Thank you very much, Dr. Kofidis, Dr. Mitropoulos. As the local surgeon, I'm going to do what I can to save on time, because I always remember the talk is usually most enjoyed by the person giving it, so we'll try and be quick here. So managing the small aortic root during aortic valve replacement, we'll talk about what aortic root enlargement is, in which situations we should perform this procedure, how do we perform it, is it safe, and what are the implications for future valve-in-valve. This is the anatomy of the aortic root. As all of us know as surgeons, we look at this every day, and our cardiologists look at this usually with echo. You have the coronaries, the conduction system, the anterior mitral leaflet. These are all areas that we're going to be looking at when we perform an aortic root enlargement. So there are multiple versions of this procedure, whether it's the Manugian, the Nix, the newer Yang technique. All of these aim for one thing. You're trying to put a larger aortic valve in, essentially, than the patient will fit. So I'm just going to simplify this. The Nix, the Manugian, all of these are basically cutting down into the aortic annulus. You're using a patch of various materials. It can be bovine pericardium. You can use whatever material you like, Dacron, to enlarge the root and put in a larger valve. What's the problem with the small annulus? Why are we doing this? You know, I talk to our cardiologists when we're doing TAVI every week, and one particular cardiologist said, Greg, why don't you just put in a bigger valve? And it's like saying, okay, well, if I give you a size 40 shoe, can you put a size 45 foot into it? No, you can't, because that's the size that the patient has. So we need to perform an enlargement. So the problem with a small sized annulus is that you're going to get prosthesis-patient mismatch. And so when we look at the effective orifice area and the body surface area of the patient, we know that you need a certain size valve for a certain size patient. Otherwise, you run the risk, as noted here on this slide, of higher gradients, more likelihood of heart failure, worse quality of life, more hospital readmissions, increased risk of reoperation, increased valve degeneration. The list goes on, but there are a number of negative outcomes tied to patient prosthesis mismatch. That's why we have these sizing charts, and so various companies come up with these charts, and they tell you that, Dr. Pattakos, your patient has a BSA of, let's say, 2, and so for this patient, you need this size valve to be in the green zone with no patient prosthesis mismatch. With this size, you go into the yellow. With this size, you go into the red. So let's see what a BSA of 2.2 looks like, because this is where you start to get into trouble and to need larger size valves. So when you have patients that start reaching 100 kilos, especially if they are shorter, then they start to have a larger BSA. So when a patient walks into my office and they have a short stature and a very large body mass index, then I know that this is a patient, especially especially older women who have a few extra kilos. They're at very high risk of PPM, and I can envision that we're going to need this procedure. This is one of the more important papers noting this. So when you look at patients who got a 19 millimeter valve and what are their outcomes with this valve. So mean follow-up of 4.9 years, 447 patients, 54% of them received a 19 valve. What happened? What did we see? Patients who got this 19 valve had a higher gradient and more patient prosthesis mismatch, although in this study there was no difference in overall survival, cardiac-related mortality, or MACE. However, we know that the impact of prosthesis patient mismatch through many studies is great, whether it's after SAVR, after TAVI, or after both. So this is not purely a surgical phenomenon. This is just an aortic valve phenomenon. If you need a valve, you need to get the biggest valve you can. And the reason that this is important, and I don't want to talk about it in isolation today, is because more patients want biological valves. And so when you're going to put a biological valve in a younger patient, in SAVR, and you see the outcomes, especially for asymptomatic patients, the guidelines only recommend SAVR. So you're not going to be doing TAVR in asymptomatic patients, at least if you want to be following the guidelines. You're going to be putting mechanicals in under age 50, but the US guidelines and bio over 65. However, a 50-something-year-old may be a candidate for a biological valve. For the European guidelines, they're slightly more, they have different age criteria, but 75 they're looking at for TAVR. So what are the key steps for getting many decades with a biological strategy? The most common strategy is to do a SAVR and then TAVI in SAVR. However, there are a variety of ways that you can do this. The most important thing is that the first valve should be as large as possible. And when you look at this, it's interesting that the marketing that the transcatheter valve companies have, and our friends at Medtronic, they have an advertisement that says, only one TAVI device showed superior hemodynamic superiority to surgical valves. What's the reason for this? You see this in the Evolute low-risk trial at 3 years. Because in the Partner 3 trial, a number of patients, 21, and I always go into the supplementary appendix and look at the nitty-gritty, a number of patients in the Partner 3 trial had root enlargement. So when you look at the Partner 3 trial, surgery had better effective orifice area than TAVI because of aortic root enlargement. So this is one of the nicer videos I found online. I'll show you our case, but we don't have as good a videographer as they do in Toronto, apparently. Dr. Davirwala is looking at this as well. So this is a very nice aortic root enlargement that they performed in Toronto. You can see how the aortic annulus is opened. This is our version of the case. I don't have a video, but photos that I think Dr. Spiridakis, our anesthesiologist here, may have taken. So this is the aortic root. You see the bovine pericardium being sutured to the aortic root, and you can usually get a valve that's 2 sizes larger in. And you see here how we use the bovine pericardium in order to close the aortotomy. Now, I'm only going to be a few minutes longer here in the sake of time. When you look at the safety of these procedures are very safe. And the most important thing that you see in this meta-analysis is that patients who had a small aortic root, even though we know that overall as a patient population they do worse, when you perform an aortic root enlargement, they do as well as an age, sex, annulus size comparison population will do. So you see that when you take patients with a small aortic root and do an enlargement, 809 patients in this study from Ontario, they're doing very well with cardiac surgery in Canada, obviously. There's no difference in survival, CHF readmission, and aortic valve reintervention. So you take an aortic root enlargement patient, and they are just as if they had been born with a 23 or 25 size annulus. Not to mention that these procedures, a number of these procedures have been shown to decrease the risk of coronary obstruction in the future when you're going to need to do a valve-in-valve procedure. Our good friend here and pioneer in transcatheter valves, our friend Vinny Bapat, has come up with its technology of biological valves where the ring can also expand. So aortic root enlargement plus these valves are really the future for patients who want a biological strategy. So for young patients, yes, they're still going to be receiving mechanical valves. For slightly older patients who want a biological valve, it's very important to get the largest biological valve size in that's possible. This will frequently be with a root enlargement. So this is what we want. This is the focus, I think, of most of the talks today. Our patients really want minimal surgical trauma. This is our mini sternotomy AVR. And they want the biggest valve possible through the smallest incision possible. It sounds hard, but it's not as hard as it sounds to do. We've seen a number of surgeons here at the Pantheon today of minimally invasive surgery. And I thank you. I did my best to be quick. My conclusions are that aortic root enlargement is a useful technique for patients who are at risk for patient prosthesis mismatch. The technique is safe and has durable outcomes. And for patients who are young but still want a biological valve strategy for their aortic valve replacements, it's very important that the first valve placed be as large as possible. Thank you very much.
Yeah, Greg, thank you so much for a fantastic talk and most meaningful comments and messages that you lay across. In the context of preserving time, we would like to finish the session here and proceed to the next one. Thank you very much for your attendance.